Hello, this discussion will include coronary artery disease and angina. We will pick up ACS in class when we meet on Thursday. So coronary artery disease, or CAD, as you may know, is the most prevalent type of heart disease, and it's a leading cause of death for all genders and ethnicities here in the United States. It occurs when the coronary arteries, which supply blood to this heart muscle, narrow and harden due to cholesterol and plaque buildup. This obstruction, primarily caused by atherosclerosis, can lead to insufficient amount of blood and oxygen supply to the heart muscle, and this results in chest pain or angina. It can also result in an MI, which we'll talk about. Over time, CAD can weaken the heart muscle, and this can lead to heart failure or dysrhythmias. So I have a picture here of the coronary arteries on the left. Look at those coronary arteries and think about if they were diseased with plaque, how would that affect the function of the heart? So for example, if we have the right coronary artery here, think about your SA node and your AV node and all of those things that are in that right side of the heart there and how they would function if there was a diseased artery there, not perfusing that area. Think about your rhythms, what they will look like, maybe some right-sided heart failure, things like that. So we'll get into our discussion about ACS and really think about your structure of your heart and the coronary arteries, where they're located and how they help the heart to perfuse the body. And absence of their a good function, what can happen? I always look at this left anterior descending coronary artery and look how big it is right in the front there, in front of your left ventricle. If that was diseased, how would that affect cardiac function? So think about that. And then look at the picture on the right, really look deep at the fibrous plaques and the lesions that develop from this disease process. So that in mind, we'll talk about the risk factors for coronary artery disease. Some things that we can modify and have our patients modify if they are at risk for coronary artery disease are things like smoking, alcohol. Lots of alcohol intake can cause coronary artery disease. Stress levels, activity, and obesity. Sedentary lifestyle contributes to coronary artery disease. Diabetes type 2, hypertension, and hyperlipidemia. These are all things that patients can modify to reduce their risk for coronary artery disease. So if we think about our prevention for coronary artery disease, we're going to tailor our interventions on teaching our patients and helping them to learn how to prevent these modifiable risk factors. So, for example, if the hyperlipidemia is a modifiable risk factor, think about how we can control cholesterol. Any dietary interventions you can add into your education: low saturated fats, high soluble fiber, decreased red meats. So our total cholesterol, as we know, should be less than 200, with LDLs less than 100 and HDLs less than 40 in males and greater than 40 in males and greater than 50 in females. Think about your triglycerides too. They should be less than 150. Some patients can do this with, diet. Some patients might need medication. So we think about our statins, how they work, and other types of cholesterol medications that they can be started on if they can't manage these from a dietary perspective. Think about ways that we can teach them to increase their activity, to lower their weight and things like that. Some medications that work for hypertension, things like beta blockers, are great because, as we know, hypertension affects the walls of the vessels and it increases the workload of that left ventricle. So managing that hypertension will increase our myocardial oxygen consumption by decreasing the workload on the heart. So those are really good. Teach them cessation of smoking, because we know that smoking increases our heart rate and our BP and affects the vessels. And then controlling diabetes, particularly type 2, and all of the metabolic syndrome that goes along with that. Non-modifiable symptoms, there's things we can't change. So men have a higher risk of CAD than women. African American race has a higher risk. Diabetes type 1 carries a higher risk. Men that are greater than 45 and females when they are greater than 55. And there's also a hereditary component that we just can't change. So as nurses, we look at how we can teach strategies and implement interventions that modify the preventable things to reduce the risk of coronary artery disease in our patients. Okay, so coronary artery disease, what it looks like, often it's silent, so patients may not even know they have coronary artery disease until 40% of that coronary artery becomes occluded. Then we'll start to have myocardial ischemia, so lack of blood flow to that coronary vessel. Symptoms and complications are related to the location, like I just showed you on the picture there, the location of the vessels and the degree of the occlusion. So if we have a 50% occlusion, we're going to have maybe less symptoms than an 80% occlusion in whatever vessel. So think about that. The primary manifestation, though, for patients is angina. You may have heard it, angina pectoris. This is the most common manifestation of coronary artery disease. Again, it doesn't happen usually until we have greater than 40% occlusion. So angina is chest pain, and this occurs due to the ischemia of the myocardial area. Other symptoms you might see, some patients have epigastric distress. They may have pain that radiates to their jaw or left arm. They may have shortness of breath. Some patients have atypical symptoms, and this can be men, women, or patients with diabetes. They can have atypical symptoms. So it's important to note that not all patients have, crushing chest pain when they have angina. They may just have shortness of breath, or they may be tired. Diabetics can often have GI symptoms, so it really depends. But note that some patients may not have the classic angina that you would expect. Other manifestations of CAD would be an actual MI, heart failure, or dysrhythmias, or sudden cardiac death. So think about the dysrhythmias we've talked about in class already, and how this puts them at risk for dysrhythmias. So angina can be broken down into 3 different subtypes. We'll talk about them here, and there's pictures of each of them. We'll start with stable angina. This is caused by chronic narrowing of the coronary arteries, and this is usually due, again, to atherosclerosis, which is that buildup of plaque. This is a fixed plaque, so the plaque is there already, it's staying. The pain is usually predictable for patients. They may have pain in their chest that usually occurs when they're exerting themselves or they have stress. It usually lasts a few minutes, and it can be relieved with rest or nitroglycerin. Things that we can do for treatment is we can teach lifestyle changes. We can, teach them and, assist them with medications that manage their risk factors like statins and antihypertensives. Anti-anginal medications like nitroglycerin is one that will open up our coronary arteries, decrease our preload, and help to relax that coronary vessel. So those are important in the care of a patient with stable angina. Beta blockers are also helpful, calcium channel blockers, so think about your mechanism of action there and how that would help in this situation. And some patients may need revascularization procedures, things like angioplasty or stenting or bypass surgery, which we'll talk about later. There is a different variant of angina that you may or may not see in practice, but we'll bring it up because it's in your book. This type of angina, this variant angina, it accounts for less than 2% of angina that comes into hospital settings. They're not real common, but they're caused by a coronary spasm. So in this case, they're not related to that atherosclerotic lesion. They're related to an actual vasospasm. And it's caused by a spasm in the coronary artery. And these spasms will temporarily narrow or shut down or close that perfusion through that artery. The pain in these type of Prinzmental angina attacks is what they're called. They typically occur when the patient's at rest, often at a early morning or late night. And they last for a few minutes to several hours, depending on the spasm. The triggers for this type of angina can be cold weather, that you see this more often in the cold. Stress, of course, will do these kind of things. Smoking, some medications, we think about ephedra and anything that increases that heart rate, and cocaine use, things like that. We see this type of chest pain then. The treatment, when a patient comes in with this type of angina, this variant angina, we'll often treat with medications that relax the coronary arteries. So again, things like nitrates and calcium channel blockers are big in this treatment. Unstable angina, now we're getting a little more serious. This is caused by the partial or temporary blockage of a coronary artery. So you can see there in the picture. It's often due to a rupture of an atherosclerotic plaque, and then after that plaque ruptures, the patient will develop a clot on top of it. That's your body's way of trying to protect you from injury. In this case, it impairs our circulation, so it's not good. So this is caused by a thrombus, this type of unstable angina. So there's a clot there on top of that clump of atherosclerotic plaque. So ischemia is present, but it may not be enough to cause cell death. So the pain occurs unexpectedly, and it's more intense, and it's definitely a longer duration than someone with stable angina. This can occur at rest, or if the patient is like exerting themselves, and it's not relieved by rest or nitroglycerin. So that's how we know it's unstable angina. The time it usually lasts is longer than 20 minutes. So that's a long time. So if the patient's resting, they've taken their nitro, and they're still having the pain, this is a big deal. So now they have unstable angina. An EKG on this patient may show transient changes, so that come and go, such as you may see T-wave inversion or ST segment depression. You may see that on the EKG. It doesn't show ST segment elevation. That's not this situation. That would be a ST elevation MI or a STEMI. So in this case, we may see some T-wave inversion or some ST segment depression. If you're familiar with troponins, which is our cardiac markers, which are lab values, they will not elevate with this type of unstable angina. So that's how we know we don't have an MI. When we don't have the presence of high troponins, we don't have an MI. So right now in this unstable angina portion here, we are not in that, I can't say we're not in the danger zone, but we're not in a situation where we have an actual MI. So treatment for someone with unstable angina includes antiplatelet therapy. So we'll have the patient take aspirin. So they'll take 4 baby aspirins and they will chew them. They may already be on a statin, but if they are not, then they will need one because we want to control that cholesterol. And these are also helpful for patients that don't have high hyperlipidemia. So they give them with patients with CAD. So they may need a statin. They may get a beta blocker depending on what's happening with them, because again, they will decrease the workload on the heart and increase that myocardial oxygen consumption. Nitrates, again, we'll give nitro. So typically we give the patient, if they know they have angina, they had it before, they'll have a nitroglycerin prescription, which is that little bottle that is, light should not hit it. And they will take 1 sublingual nitro, put it under their tongue. It should burn. We want to know that it's burning, because then we know that it's not an expired or, tampered with nitroglycerin. Like, in other words, it hasn't been hit by the light, so it's still working, and the patient should get a headache from it. Hopefully it will relieve their chest pain. If it does not, then in 5 minutes they can have another one, and in 5 more minutes they can have a third one. Each time that they take one, this whole time they should be resting. If the third nitro does not get them the help that they need, then they need to come and be seen in the emergency department right away, because we don't know, is this unstable angina or is this an MI? Because these patients are having pain and they don't have an EKG at home, so they need to come in. We will give them morphine to help control their pain. We'll give them oxygen if their O2 sat is low enough to warrant it. And this may require a revascularization procedure, again, like angioplasty, stents, or bypass surgery. So these patients that have the unstable angina, chest pain's not going away, it's been 20 minutes, they'll come in the emergency department, stat EKG, and start them, with morphine if they need oxygen, and the nitrates if they haven't had it already. Okay, so we go from there, and we look at their ST segment, we look at their T waves, and we see that there are changes. So this is a big deal. Then we will get their lab work, so we'll get the troponin, and we'll notice that that troponin is not elevated. So that's our clue that it's possibly unstable angina. We will continue this discussion in class. We'll talk about acute coronary syndrome, or ACS, which is an all-encompassing form for, it's like an overarching word that we use to describe patients that have that unstable angina or they're having an MI. So if you look here on the graph at the bottom, USAP is that unstable angina pectoris. The NSTEMI is a non-ST elevation MI, and the STEMI is an ST elevation MI. So when they say ST elevation or non-ST elevation, we're talking about that ST segment on our EKG. So think of where your ST segment is and how that would look if it was elevated. Okay. So they'll come into emergency department, they'll have chest pain. If they get an EKG and there's not ST elevation, but there are ST changes like a T wave inversion or ST depression, then they put the patient in a category of, unstable angina or non-STEMI. So to differentiate the unstable angina, we know that their troponins and their CKMB potentially are normal, and they don't have ST elevation. The patient who has a non-STEMI, they do have high troponins. They may have some ST changes, again, ST depression or T wave inversion, but their cardiac markers are high. If we're looking at a patient that has, if we look right at their EKG and we see ST elevation, they are having an MI. So it's called a STEMI. So this is a serious situation because no blood is getting into that patient's coronary artery because it's blocked. So we'll talk more about that in class. Go through your PowerPoint and the reading so you can be prepared. And we will pick this up with acute coronary syndrome.